Hello, welcome, and thank you for joining us today for our educational webinar entitled Hereditary Hematologic Malignancies, Not That Rare. I'm Dr. Katrine Erickson, the Executive Director of the RUNX1 Research Program, which is a nonprofit dedicated to supporting patients with RUNX1 familial platelet disorder with a very high predisposition to hematologic malignancies. We have one goal, and that is to prevent cancer in our patients and improve the quality of life overall. Aside from funding research and building and supporting our patient community, we raise awareness of these germline predispositions to hematologic malignancies and the importance of their diagnoses. The need to improve diagnosis of hereditary hematologic malignancies is why we're all here together today. I do want to acknowledge our premier sponsor, NeoGenomics, for supporting this webinar. So here's the agenda for the webinar today. We have a packed agenda, and we'll begin with a presentation by Dr. Courtney DiNardo of MD Anderson on when to consider, how to evaluate, and how to treat hereditary heme malignancies, followed by a panel discussion and Q&A session with experts from around the country whom I will introduce at that time. Please remember to submit your questions throughout the presentation by using the Q&A icon at the very bottom of your screen. And I believe with that, I will turn it over to Dr. Courtney DiNardo to introduce herself and share with us her expert knowledge on this very important topic.
Hello, everyone. Courtney DiNardo here from MD Anderson, where I am in the adult leukemia program, but also have set up over the past decade or so, really, the Hereditary Heme Malignancy Clinic at MD Anderson. So I'd like to share with you today some of my experience and overall just understanding that the hereditary hematologic malignancies are not so rare, actually. And the more you think about them and are paying attention to the evaluation of patients, the more you're actually going to realize that this is something that is an issue for probably many of your patients with heme malignancies. So we'll go through that data, considering, evaluating, and also treatment implications for these patients. Here are my disclosures. And so the key learning objectives are to learn the prevalence of pathogenic germline variants in heme malignancy patients, to understand the importance of germline genetic testing, gain tools on how to suspect and diagnose hereditary heme malignancies, as well as learn how to manage hereditary heme malignancy patients and their at-risk family members. One of the common questions I get to start, which is actually one of the most challenging questions of all, is how common are hereditary heme malignancies? And the overall incidence really isn't well defined. And this is a busy slide just explaining why it's not very well defined. We've had limited training and experience as providers on how to identify and evaluate these patients. Genetic testing, even when we want to do it in these patients, is really quite complicated. It often requires a skin punch biopsy where you're culturing skin fibroblasts to do testing. Because remember, in a patient with a leukemia or another hematologic malignancy, that circulating tumor is not an appropriate assay or medium to test for what's underlying in germline. If you're doing genetic testing on the blood of a patient with circulating leukemia, you have no idea what's germline inherited or what is acquired somatic as part of the leukemia. We know many patients who have a clear familial risk. They have MDS and AML in their families for generations, and yet their testing is negative. So there's certainly other genes at play, or maybe variants of uncertain significance we haven't annotated yet will end up being pathogenic. This is a new field for us. We also know that not all patients with confirmed germline mutations will have that strong family history or that strong personal history of multiple cancers that would have suggested referral. And so, this is highlighted by DDX41, which we'll talk about, that is a much older onset, as well as, incomplete penetrance and new de novo mutations. So overall, probably about 15 to 20% of patients who are referred for genetic testing with a heme malignancy will have an identified hereditary heme malignancy, with an overall incidence in our patients of about 5 to 15%, which is really quite similar to solid tumors. And so even though we haven't really thought about it as much as a field, it really is just as much of an issue in our patients as those with solid tumors. This is just an example of what we had seen at the MD Anderson Hereditary Heme Malignancy Clinic in 1 year on the left. So we performed over 100 skin punch biopsies where we cultured skin fibroblasts. We did testing, but 20% of patients had an identified pathogenic predisposition. The majority of them are DDX41. We had patients with short telomere syndromes, germline GATA2, LFS is Li-Fraumeni syndrome, RUNX1, SAMD9, Fanconi anemia, Diamond-Blackfan anemia, Swashman-Diamond, Elaine, the list goes on. And it starts to become a bit of a laundry list as I go through this talk. But, bear with me because these syndromes are all a little bit different. And I think it's important as providers that we know some of the differences between these. And this is consistent in this pie chart, which is not my chart. This is a separate analysis looking at patients with MDS and AML that was published in Nature Communications and overall shows fairly similar percentages. Why is this important? Well, the diagnostic guidelines, we use the WHO classification, includes myeloid neoplasms with germline predisposition. So this is something that is important for us in terms of appropriately diagnosing our patient. But more than just diagnosis, of course, it allows us knowledge on how to optimize the treatment of our patient. For instance, patients with the bone marrow failure syndromes, you really have to be careful with the intensity of chemotherapy and transplant conditioning that you're using. There's hope for precision medicine. One example is lenalidomide for patients with DDX41 mutations. Really importantly, in our patients, stem cell transplantations are, of course, curative options that we are thinking about all the time in our patients. And we really want to optimize the best donor. And so sometimes in a patient who has a family history of hemalignancies, the optimal donor is going to be an unrelated donor and not the family member who is fully matched, but yet has a shared predisposition. This, of course, not only impacts the patient that we're seeing, but also provides future opportunities to identify, screen, and maybe in the future prevent hemalignancies in the asymptomatic family members that could be carrying the same predisposition. I get this question a lot. So just to highlight the fact that there are laws to protect individuals who are getting genetic testing performed and in patients who have a underlying inherited predisposition identified. This is not true for life insurance. And so we often counsel our patients, if possible, life insurance is something that should be had prior to testing. It's called GINA, the laws that protect patients from genetic discrimination. So this is something that genetic counselors spend a lot of time talking to patients about, but just I think important for people and providers to be aware of. My last background slide is just to kind of give you a sense of the scope of this. So when we started our hemalignancy clinic at MD Anderson back in 2014, we offered testing 1/2 day a month, and we saw a patient here or there. But this has just exploded. And it's just, I think, a nice example of if you're paying attention, you realize how much of an issue this actually is. We're seeing about 25 patients or more sometimes a month now, despite COVID. And now we actually have telemedicine opportunities because of COVID that allows an even greater reach. This is an overwhelming slide looking at many of the predispositions syndromes out there. And in red are the ones that are new since we even started doing this a couple of years ago. And it just shows you kind of the pace of discovery and how much we've realized that our testing really needs to be iterative because the patients I tested back in 2015 didn't have a comprehensive panel according to our 2022 definition, which is probably going to be different from our 2025 definition as we learn the various different genes that are underlying hereditary predispositions in our patients. But we'll go through some of these, and I've kind of grouped them into the inherited bone marrow failure syndromes that can present in adults, because there's a whole lot of pediatric bone marrow failure syndromes, but there's a handful of them that are more commonly identified in adults that I think we need to be aware of. The familial MDS acute leukemia syndromes, which aren't so much syndromic per se, and then we'll talk a little bit about the familial lymphoid disorders. When I'm seeing a patient, family history is very important. You want to know about family history of hemalignancies, early onset of other cancers, multiple cancers, and close relatives. You want to know their personal history. Have they had a bone marrow failure or a hypocellular MDS or AML at any age? In particular, patients who are diagnosed at young ages. Not that you can't have an inherited hemalignancy at an older age, but if you are younger, it is even more likely that you could have had a inherited bone marrow failure syndrome. So this is what I'm going to focus on over the next couple of slides. The other things that are really important to think about that are not so much a hemalignancy in and of itself, but does your patient have a history of frequent infections or hospitalizations or platelet transfusions or blood transfusions when they were a kid, when they had an infection and their bone marrow gave out? Do they have unusual skin or nail findings, pulmonary fibrosis, liver fibrosis? These types of things are getting you towards, could there be some sort of inherited bone marrow failure syndrome, which really links with immunodeficiencies? We do a gene panel, which we'll talk about, but the other things that are standard of care and are not a gene panel itself are doing a DEB or mitomycin C chromosome breakage assay, looking for Fanconi anemia, and telomere length analysis using FlowFish for the short telomeres. These are send-out tests. They take about 2 weeks and really should be done in conjunction with genetic testing. On the left is your standard bone marrow with some fat cells and a whole lot of other bone marrow making the things it's supposed to, as opposed to a hypocellular MDS or bone marrow failure where there's really just not much hematopoietic precursors at all. About 70% of the time, this is idiopathic. About 10 to 15% of the time, it's secondary to various different drugs, chemicals, radiation, or immune mediated. But about 15 to 20% of the time, it is likely inherited with, again, some of these bone marrow failure syndromes, Fanconi anemia, dyskeratosis congenita, which we now call short telomere syndromes, Swashman-Diamond, Diamond-Blackfan anemia, and others. And so I want to highlight two in particular. So Fanconi anemia is a biallelic autosomal recessive condition where you have defects in DNA repair proteins. People know about BRCA1 and BRCA2, of course, causing breast and ovarian cancer syndrome. But if you have two BRCA1 or two BRCA2 or two FANC-A or any of these other genes shown on this pictorial, that gives you a diagnosis of Fanconi anemia. Patients often present with bone marrow failure or hematologic malignancies in childhood, the vast majority. But about 10% of patients will present in their late adolescence or young adulthood. And of course, it's the patients that have more mild phenotypes that are the patients that are diagnosed in adulthood or later adolescence that weren't picked up by their pediatrician. So about a third, as you can see at the bottom, bolded, do not have congenital abnormalities. And this is a chromosome instability syndrome. Patients have a really hard time tolerating DNA damage. And so that is shown when I had said do a chromosomal breakage analysis. This is an example of what mitomycin C does to the chromosomes of a patient with Fanconi anemia. You can see these radial ray defects and just pretty significant abnormalities to what is supposed to be a normal chromosome spread. This in the patient leads to reduced stem cell survival. And again, many patients with bone marrow failure at childhood and early adolescence. In adults, you have a very significant risk of MDS AML as well as squamous cell cancers of the head and neck, skin, GI, and GU. So in patients with Fanconi anemia that I'm seeing, in addition to monitoring them for heme malignancies, I'm also monitoring them for a risk of solid tumors as well. This is an example of what you would consider like a typical Fanconi anemia patient that we saw in our clinic. A 15-year-old female, short stature, had been transfusion dependent off and on from birth. She had certain skeletal defects, including absence of her thumbs. And so this was someone you were suspecting that there could be Fanconi anemia. And indeed, when we did our DEB assay, it was positive, showing us that she did have a diagnosis of Fanconi anemia. And then the gene panel that came back showed us that she had two different BRCA1 gene mutations. And she is now doing well after transplantation. This is an example of a more unexpected Fanconi anemia patient, again, highlighting the fact that you really need to be thinking about these things or you might not notice. So 28-year-old African-American male, pretty healthy, no skeletal defects, no underlying congenital abnormalities. He was relatively short, well, not even 5'5", but everyone else in his family was much taller. His brother, for example, was 6'2". He presented with pretty symptomatic and dramatic anemia with a hemoglobin of 3. A bone marrow biopsy was done in this otherwise healthy 28-year-old with multilineage dysplasia, a hypocellular marrow complex cytogenetics. So kind of unusual. Why would a 28-year-old have this complex MDS structure? And the DEB assay that we did on him, just as a routine, someone in their 20s with MDS, we do a DEB assay in telomere flow fish, and it confirmed a high degree of chromosomal breakage. He actually declined genetic testing to find out which the specific gene was. So I don't actually know which of the many Fanconi genes it was, but it doesn't particularly matter in this sense because he is moving forward with an unrelated donor transplant. We could test siblings with the DEB assay looking for chromosomal breakage, which we did, and his brother does not share in the diagnosis of Fanconi anemia, but was not a great match for a transplant. The other disorder I want to highlight in the inherited bone marrow failure syndromes is what we used to call dyskeratosis congenita, but we now have several different names: a short telomere syndrome, telomere biology disorder, or telomeropathy syndrome. So if you hear these things, they're all interchangeable, and it's because we're trying to get away from the phrase dyskeratosis congenita because there's a DKC1 gene that is one of many, and it was, I think, a bit confusing. Telomeres in this schema, in this figure, are the red caps to your chromosomes, and they're repeats of DNA to help protect the key material in your chromosome, which is your DNA, from being degraded with replications and life and exposures and toxicity. And so the telomere length itself is part of what regulates the ability of cells to continue dividing. There is telomerase, which is able to extend the telomere length in cells that are continually dividing, like stem cells. And of course, cancer cells exploit telomerase because they want to keep replicating and evading cell death. And so that's something that is frequently exploited by solid tumors. Again, when you talk about dyskeratosis congenita, right, there's this classic triad that you're supposed to see, which is highlighted here, which is in the middle, this reticular skin rash, oral leukoplakia, and nail dystrophy. And I think part of the reason that we don't call it dyskeratosis congenita anymore is because this is very specific to the X-linked DKC1 gene that happens in young males who have this classic triad. But if you're waiting for this classic triad to come into your office to diagnose a patient with a short telomere, you're going to miss a lot of these patients, because I don't think I've seen more than like 2 patients in the dozens with short telomere disorders that actually have this triad. You'll see probably some patients with a reticular type rash, maybe some pitting nails, maybe some oral leukoplakia, but it really looking for that cohesive triad is relatively unusual in the adults that we're diagnosing. Similar to Fanconi anemia, they have a very high risk of not only heme malignancies, but also squamous cell carcinomas, as well as pulmonary and liver fibrosis. It's actually quite interesting. There's the idiopathic pulmonary fibrosis patients, and genetic testing in those patients and families has identified many patients with pulmonary fibrosis, if unclear reasons actually are related to underlying short telomere disorders. So there are age and mutation-specific phenotypes of short telomeres, and DKC1, you can see, I've talked about that once or twice. That is the X-linked mutation that tends to affect boys in their adolescence and early adulthood with that classic triad. In the adult world, what you're probably going to see, what we've seen more of, is TERT, TERT, and also RTEL1. And these patients tend to be diagnosed not with as many constitutional syndromes, but actually presenting with a hypocellular MDS or AML. And the slides on the right, A and B, especially B in particular, I like because it shows the younger patients tend to present with aplastic anemia. The older patients tend to present with often hypocellular MDS or AML. And this is a patient that we've diagnosed here. Hypocellular low-risk MDS, diagnosed in his early 50s. He actually didn't have a family history of MDS or AML, but his brother and father died of pulmonary fibrosis. So again, that idiopathic pulmonary fibrosis. And he actually, on just screening scans, did have some early fibrosis identified also. He had premature gray hair, and actually this is something that we do see quite a bit. Premature gray hair in patients with short telomere syndromes, had a TERT mutation confirmed, and he has actually been doing quite well on a low-dose azacitidine program, and ultimately will probably get a transplant at some point in time, but is not yet prepared to move to transplant. These patients do have a significant risk of transplant, especially pulmonary and liver toxicity. So for patients with short telomeres, we are definitely thinking about the transplant conditioning regimen pretty carefully, and we could potentially talk about some of that in the Q&A session later. In terms of how we monitor these patients and treat these patients, it is known that patients who have inherited bone marrow failure syndromes, they unfortunately respond pretty poorly to your standard ATG, cyclosporin immune therapies. And so what has been shown is that growth factors, and especially androgens like danazol, have been effective in treating these patients. More than 50% of patients will respond to danazol. So this is something that we're often starting in our patients. And again, as I mentioned, just particular attention to reduced intensity regimens for patients with these inherited bone marrow failure syndromes. They have a hard time tolerating cytotoxic therapy and radiation and intensive conditioning regimens in particular. Want to make sure we're highlighting with each topic as we go the importance of testing sibling donors, because the last thing you want to be doing is transplanting a patient back with the same underlying predisposition. And then again, patients, especially post-transplant, but all of these patients need solid tumor surveillance in addition to follow-up for their malignancies. All right. So that was the whirlwind tour of inherited bone marrow failure syndromes in adults. And so we'll move to just some examples of patients with familial MDS and acute leukemia. We can't go through everything, but I want to highlight some of the key syndromes, I think. First is GADIT2, familial GADIT2 syndrome, which we used to call monomac or Amberger syndrome. And more recently in this genetic sequencing era, we realized that monomac and Amberger syndrome and germline GADIT2 are all actually the same diagnosis related to pathogenic GADIT2 mutations or deletions. The average age of presentation in these guys is again late adolescence, early adulthood, but it has been diagnosed across the board. About a third of patients with a germline GADIT2 will have a de novo mutation, so they won't have a family history, and testing of their parents will be negative. So it's one of the higher rates of de novo diagnoses in the hereditary heme malignancies, and they have a very high lifetime risk. of developing MDS or AML, about 75 to up to 90% in some studies. The story of these guys is that they have frequent underlying atypical infections throughout their life. You will also have a story, if CBCs have been done routinely, they will have B-cell and monocytopenia in the setting of these infections. Oftentimes they are diagnosed with a hypocellular MDS or AML as well. You can see along this figure a whole host of various different abnormalities. Some of the more specific ones are extragenital warts, so like periungual or genital and extragenital warts. Paniculitis and enodosum are pretty common, as well as lymphedema in patients without underlying cardiovascular disease. This is very common in pediatric and adolescent MDS patients, especially if they have monosomy 7. And so if you have a 18 or a 20-year-old patient with a monosomy 7 MDS, definitely be thinking that there could be a germline GATA2, because about 3/4 of the time there is. You don't see germline GATA2 on the left in these circles is kind of looking at various different cohorts of pediatric patients with MDS. You don't see it in the secondary MDS patients that have had treatment for other cancers and then have a therapy-related MDS. But in primary MDS patients, this is common, again, especially with the monosomy 7. And you can see, especially in that older child, young adolescent population, you're going to see those patients have a high likelihood of germline GATA2. This one is an 18-year-old man who did have a monosomy 7 in addition to a MECOM translocation 3-3. He was referred because he had a mosaic germline GATA2 mutation identified when they did testing on his peripheral blood when he had a high degree of circulating leukemia. And so they said he had this germline GATA2 mutation, but actually GATA2 is on the chromosome 3. And in this gentleman who had a chromosome 3 abnormality as part of his leukemia, that's what we were picking up. The fact that he had this deletion of 3q because of this chromosomal abnormality. And so when we did testing on skin fibroblasts, actually, there was no gene deletion identified in that germline sample. So it's just a good example showcased here of why you can't just assume the testing that you do on the blood of a patient with circulating leukemia. It's not only potentially negative, it's potentially positive, telling you there's something there that actually is related to the somatic leukemia itself. On the flip side, we saw a 23-year-old man with hypocellular MDS with a monosomy 7. No significant family history, but he was one of those patients that almost certainly, right? You're looking at this patient with recurrent paniculitis, skin infections, periungual warts is shown here, hard to control. And you're thinking, gosh, this just doesn't make much sense. We did flow cytometry and he had absent monocytes, decreased NK cells, B cells, and we did his sequencing and there was no pathogenic GATA2 mutation. There was this benign variant GATA2, which raised everyone's eyebrows, but that was a benign variant. So we're like, gosh, what is going on? And actually, we have a collaborator across the street, Dr. Emily Mace, who looked at our patient samples in red here, and this patient had no NK cell function. The control on the top is what it should look like, and then on the bottom, his NK cells, you know there's some sort of issue. And ultimately, he had a variant, a pathogenic variant in the intronic region of GATA2. And so standard sequencing missed this pathogenic variant, and actually about 10 to 15% of GATA2 patients will have an intron mutation. And so it just, again, highlights the fact that you need to make sure you're doing testing through a lab that is doing testing of hereditary heme malignancies well. If 15% of patients with germline GATA2 can have variants in the intronic regions, you got to make sure the intronic regions are being tested. It's called del-dup analysis, deletions, duplications throughout the gene itself. And this is something that most labs that are CLIA approved for genetic testing do now, but if you're having this done at your institution and that's not standardly done on your assay, you're going to miss patients like this. The next topic I think is really important to review are those patients with MDS and acute leukemia predispositions that also have a lifelong thrombocytopenia. So there are 3 genes in this category. They're all autosomal dominant inherited predispositions based on pathogenic variants in RUNX1, NGRD26, or ETV6. These patients will often have a lifelong mild to moderate thrombocytopenia, although many of them, if you're not getting routine CBCs done, didn't actually know that they had this mild laboratory thrombocytopenia. You can see aspirin-like platelet aggregation defects. A lot of them will have easy bleeding or bruising, maybe with dental work where you get more mucosal bleeding. Bone marrow show slightly abnormal megakaryocytes, even in a healthy individual who hasn't progressed to an MDS AML. Variable penetrance with these genes, and they affect the platelets in particular, because these are key transcription factors involved in megakaryocyte growth and differentiation. This is actually one of the very first patients we saw in our hereditary hemalignancy clinic, a very large family with so many different family members affected by MDS or AML and thrombocytopenia. And this family ended up having a germline RUNX1. Overall, about 40% of patients with a germline RUNX1 will develop a hemalignancy. So it's different than GATA2 and different than some of the others. Not all patients with a germline RUNX1 will go on to develop a hemalignancy. So it's really important, I think, to counsel patients that way. The average age of presentation is about 30 years old. In addition to the thrombocytopenia that I mentioned, the patients with germline RUNX1 also tend to have a very high prevalence of allergic and autoimmune conditions, and in particular, eczema. And this is something that I think is more and more recognized. This is another case report. This is not a patient that I followed, but from the literature that I think highlights, again, the importance of the sequencing that's being done. So a 62-year-old man, AML, history of mild thrombocytopenia, 2 children and 1 grandchild also with thrombocytopenia. You can see in the pedigree on the right, those patients with thrombocytopenia is the dark black. And the sequencing that was done identified that he actually did have a RUNX1 mutation, a R139Q, but actually it was only in him and it wasn't in the affected children or grandchild with thrombocytopenia. And so again, you're like, well, that doesn't fit with this family. And so a follow-up SNP array identified that there was a RUNX1 microdeletion in the RUNX1 gene, and that was shared by the patient and his affected relatives. When our 62-year-old male patient developed AML, he acquired the second RUNX1 somatic mutation, which can be seen in patients at the time of transformation or presentation with MDS and AML. So again, highlights the importance of the assays that are being performed. What will be particularly useful for all of the various inherited genes, but is now available for RUNX1 as one of the first hereditary hemalignancies, to have what's called the RUNX1 Registry and Genomics Database. And so the link is at the bottom here. This is really helpful as you're trying to annotate any specific variant of a patient that you're seeing. And just because your patient has a variant in a gene doesn't always mean that that gene is disease causing. And so, for example, the L56S variant of RUNX1 is a common population polymorphism. And so that is over in that benign world. And so what I want to highlight with this is the fact that you need to know, does your patient have a variant? And then also, is that variant disease causing or not? DDX41 is on chromosome 5. It leads to an autosomal dominant AML, often in older patients. So this is definitely different than most hereditary cancer syndromes where you see cancers developing early in life. You can have a patient with a DDX41 mutation happening earlier, but the average age is 65, just like the average age of a person with MDS or AML is in the mid to late 60s. DDX41 is an RNA helicase enzyme. It's involved in RNA metabolism and splicing and ribosome biogenesis and innate immune regulation. There's a whole lot to learn about DDX41, and we're just starting to scratch the surface. There have been reports of unique sensitivity to lenalidomide, even though these patients are not 5q minus MBS. You'll note again that DDX41 is on chromosome 5q, so perhaps there's some link there. On this lollipop of the genes, along the top are the various different frequent germline DDX41 mutations. In the European population, you'll see a lot of M1I and the D140 frameshift. In Asian Americans or Asian populations, you'll see more of that A500 frameshift. What is particularly interesting about DDX41 also is that when they develop a hemalignancy, they almost always will have a second DDX41 mutation, presumably on the other allele. And often it's this R525H. And so this is just something we're seeing more and more on the sequencing that we're doing in patients. You'll see a DDX41 germline mutation that's present at about 50% allelic frequency. And then you'll see this additional secondary R525H DDX41 mutation once they have developed a hemalignancy. We've looked at our patients with DDX41 mutations. We've had about 90 patients who have a mutation with a variant allelic frequency of about 40% or higher. And we have done sequencing on over 5,000 individuals. And so again, about 1.5% of our patients had a DDX41 mutation, just as the literature suggests. About half of them were referred to the hereditary hemalignancy clinic for evaluation. Almost everyone opted into testing, and almost everyone who was tested had a confirmed germline mutation. And so it just, again, highlights the fact that this absolutely is frequently germline. And we have then been able to show that just as with all other inherited hemalignancies, it's important to test potential family members who are going to be stem cell transplant donors. It takes about 2 weeks, 15 days turnaround to test family members. With DDX41, we still are trying to better get a sense of how likely it is a patient is going to develop an MDS or an AML with the germline DDX41. That currently estimated risk is about 20 to 30%. So we call it more of a moderate penetrant gene for reasons that are yet unclear, and would hope someone is working on understanding this. It's autosomal dominant, right? So both males and females are affected equally, but yet the development of MDS and AML is much more common in males. Donor-derived leukemias are a real thing, and they probably happen more frequently in patients who are getting transplanted from family members who have inherited heme malignancies. And so this is highlighted here in this slide. 2 different family members who are used as donors for stem cell transplantation with DDX41 running in the family. Of course, this was identified later, but you can have a pre-leukemic clone that actually was identified in the healthy donor that hadn't caused disease in the donor undergoing expansion in the recipient and causing leukemia, as well as novel mutations developing in the donor-derived leukemia, which wasn't apparent in the donor at all. The stress of a transplant and that need to very rapidly develop and populate an entire bone marrow and hematopoietic system puts an incredible stress on the donor's cells, leading to a donor-derived leukemia. So again, just make sure that you're thinking about donor selection. Couple slides talking about genetic predispositions to ALL, acute lymphoid leukemia. The one disorder I want to talk about in specific is Li-Fraumeni syndrome, because we're realizing more and more that both ALL and also therapy-related MDS and AML can be identified in patients with Li-Fraumeni syndrome. So this is an autosomal dominant inheritance of P53, which is a gene that is a key tumor suppressor involved in genomic stability, DNA repair, cell cycle regulation. Patients have a very high lifetime risk of all sorts of cancers. And on this picture is the different ages and the different cancers that are frequently developed. Most patients will develop their first cancer in their late 20s as a female and their early 40s as a male. Again, you'll have a pretty high frequency of these de novo mutations, so you don't always have a family history because it can be happening in your index patient. About 5% of LFS malignancies are heme malignancies. And what's super interesting is the presentation of what's called hypodiploid ALL. So this is ALL with less than 40 chromosomes. And there's this definition that I'm sure many of you know. There's near haploid and low hypodiploid and high hypodiploid. And it never really made any sense to me. It seems super arbitrary. But then you actually look at the incidence of these different chromosomes, and there really is a bimodal distribution. And in these patients with low hypodiploidy, more than 90% of patients with low hypodiploidy will have P53 mutated disease. About half of them are germline. So if you have a ALL patient, even if they don't have a history of other cancers, if they have a P53 mutated low hypodiploid ALL, be thinking that this could be a patient with Li-Fraumeni syndrome and do genetic testing for that reason. I want to finish with a discussion that I think is really important about how to do and how to think about genetic testing, because we are doing cancer genetic testing, MDS, AML, ALL, gene panels all the time in our clinics, as send-out labs, in our pathology suite. But what you get can be suggestive of an inherited heme malignancy. And the things in particular that I want you to pay attention to are near heterozygous or homozygous frequency of these mutations. So if you're getting the mutation, you also want to know what is the percentage of that mutation. Because if it's only present at about 5%, if it's a very small clone, that's not going to be inherited, right? By definition, it should be about 50%. Or if you get loss of heterozygosity, about 100%. DDX41, I talked about as something that frequently has that second R525H mutation. You'll see like 2 mutations in DDX41. CEBP alpha is the same way. So if you have a patient that has 2 CEBP alpha mutations, 2 DDX41 mutations, be thinking that one of those could be inherited. And then if you're doing an MDS AML panel and a patient who doesn't end up having MDS, right? It's some sort of rule out for a patient with ITP, but yet you find a RUNX1 mutation, patient probably has a inherited RUNX1 mutation. Or if you're doing genetic testing in a patient who's in a remission as kind of a follow-up, did that mutation go away? If it's still there and still at 50% and it's a disease-causing mutation, that could be inherited. So the MDS, AML, ALL panels that we do in our clinic are not substitutes for genetic testing, and it's going to miss those intronic variants and those promoter mutations and things. But it could provide a clue that you want to be testing and doing that genetic panel to see if one of these instances is identifying a patient with an inherited mutation. And this is just our 81 gene panel that we do. And now highlighted in these red boxes are the various different genes that actually could be inherited. And so we pay particular attention to patients who have any of these mutated genes. And there's two different things that we want to look at. In addition to what I just talked about, the other thing that's really potentially helpful for identifying if this could be inherited is that variant allelic frequency over time. So Li-Fraumeni syndrome is related to inherited p53 mutations. These mutations are almost always somatic. P53 is one of the most common genes that are mutated in all of cancers. Oftentimes they're small variant allelic frequencies. And you can see on the left, those variant allelic frequencies are all over the place. But yet there are two patients where it's almost always stable, right around that 50% variant allelic frequency. And those were the two patients that were identified to have an inherited p53 mutation, that Li-Fraumeni syndrome. Whereas, other mutations, BRCA2 as an example, DDX41 also as an example, these are mutations that, you're going to track them over time, and many of them will be inherited, and you'll see those allelic frequencies. So that's another thing that could potentially be helpful if you are at a center that is doing kind of frequent sequencing with variant detailing. And so this kind of highlights the algorithm that we use at MD Anderson. So again, we're using gene panel tests on almost all of our patients with heme malignancies. And so we're getting this information back, and it's a ton of information. So we're looking at those genes that are potentially inherited. We're looking at that variant allelic frequency. Is it above 40%, suggesting it could possibly be germline? And then we're reviewing them on a monthly basis with our pathologists and clinicians. And we're identifying, should this patient be referred for consultation, for consideration of testing to see if this mutation is in fact germline. And so this is how we have started doing this, because we don't have a normal control. There are certain institutions like Memorial Sloan Kettering, they are doing nails actually to identify normal. We don't have normal controls. And so anything we find on our MDS ALL panel could actually be inherited. We don't have that knowledge. And so this is the algorithm that we're using to try to identify patients that we don't want to miss. And so in the final minute or two, we'll talk about recommendations. What do we do with the patients that we're following that we have identified an inherited heme malignancy predisposition? This is a lot of expert opinion. There's not great guidelines out there yet. What we offer to patients is a clinical exam with blood counts, ideally every 6 months. I do recommend a bone marrow at presentation because I want to know that patient's baseline. A lot of patients, for instance, with a germline RUNX1, their megakaryocytes look a little bit funky, even at diagnosis without a heme malignancy. Patients with GATA2 can have a more hypocellular bone marrow even without MDS. So it's helpful for me to know what their baseline normal looks like, as well as looking to see, are there any secondary somatic mutations? Is there any evidence that this could already be evolving into a heme malignancy? I offer annual bone marrows thereafter for research, surveillance. Some patients are very interested in this. Other patients are not. And I don't think we have enough information yet to truly recommend this, but it is something that I do offer for interested individuals. And certainly I want to get my patients seen and evaluated by the transplant group earlier than later, because a lot of them are going to end up needing a transplant, right? And so you want to know, does my patient have a good unrelated donor option? Can we do the sequencing and evaluation of family members to know who are optimal donors, who share their HLA matched and also don't have the shared inherited mutation that would be good for a transplant if and when? There is reproductive counseling and pre-implantation genetic testing that can be done for patients that are interested, and there are specialized centers that talk about this. And this is something that at MD Anderson, our genetic counselors spend some time kind of going over and offering referrals. I think this is an important thing for people to be aware exists. And certainly future prevention approaches. We're not quite there yet, but hopefully in the coming years, we'll have some of these opportunities to help prevent leukemia in patients with inherited predispositions. And so in conclusion, I think what I want to leave everyone with is the knowledge that inherited predispositions are much more common than we appreciate. You have to pay attention to the story of your patient, their lifetime history, as well as family history. Although just because your patient doesn't have a family history doesn't mean there can't be something that is inherited in that patient. And I also want you to be aware that the workup that you want to do, it requires some coordination. You don't want to do just a simple genetic test on the peripheral blood and send it to a company, because in our patients, there's circulating leukemia and heme malignancies in that sample. And so it often requires a skin punch where you're culturing the skin fibroblasts and for those testing. And we'll, in the Q&A session, talk about this. There are academic centers like the University of Chicago that offer this. There are clinical genetic testing places that offer these services. And so knowing where your center is allowed to send these samples to and just to have that coordination in place is really important. And then it becomes much more straightforward. We talked about how the molecular testing that you get on your heme malignancy panels can help identify someone who could have an inherited mutation that you want to evaluate for, but it's not comprehensive. So just because your patient has a panel that doesn't identify something doesn't mean your patient can't have an inherited mutation in something that wasn't actually tested for, or a gene deletion or an intronic mutation that's not part of the assay that is done. So knowing kind of the specifics of the panels that are being done at your institution are really important also. Be thinking especially about testing your younger patients with hypocellular MDS, AML, aplastic anemia, the ALL patients with the hypodiploid cytogenetics and the P53 mutation. We've seen a lot of patients with leukemia that way, but the list goes on and on. So I want to end with some unresolved questions, which keep me up at night. Can the secondary somatic mutations that are identified in patients help us predict who is at risk of malignant progression? So in a patient with a RUNX1 mutation who has ASXL1 versus a BCOR mutation, is that informative? Should I be saying, oh gosh, now it's time to move to transplant, or can I still monitor this because it's not necessarily going to lead to a heme malignancy? These are future questions. Optimal monitoring and surveillance, those algorithms to really highlight how can we offer patients surveillance that is beneficial and helpful. And really key is early intervention strategies that hopefully will be coming down the pike soon. And so with that, we'll move to the Q&A session. My email is on this slide, so write it down and please feel free to email me questions about patients that you may have questions on now or moving forward.
Wonderful. Thank you so much, Dr. DiNardo. And we're going to be joined now by some additional experts from around the country, Dr. Michael Savona from Vanderbilt University and Dr. Amy DeZern from Johns Hopkins. Unfortunately, Dr. Vinod Pullerkat from City of Hope cannot join us today, but I think we've got enough experts in the virtual room here to cover the many questions that we received. So I'm really excited to jump in. And maybe what I'll do is I'll start with the question around germline tissues. There were some questions around, what do you do to facilitate the skin punch biopsy? And maybe a follow-up question is, do you use any other germline tissues to assess germline mutations? And then I'll ask a follow-up question after that. Maybe we'll start there. And I'll direct this to you, Dr. DiNardo, but I'm curious to hear what others, Savona and DeZern, do in their clinics as well.
Sure. I'll try to be brief, but it can be a long answer. But in general, it is important to have a send out testing program that you know ahead of time, because you're right, trying to figure out how to do a skin punch in real time and where you're going to send it and, the nuances of the sample collection, this definitely is probably the key point that needs to be kind of thought through ahead of time. There are a lot of excellent labs that can do genetic testing. Many of them are, send out companies like Invitae and GeneDx. University of Chicago has a phenomenal panel, and they do testing on cultured skin fibroblasts. It just depends on where you practice and where you are, insurance and the nuances of your program and where you're allowed to send samples.
Any other additional points from the other panelists? All right. Okay. Well, another question was specific to telomeropathies. Mm-hmm. And given that there can be significant workup time for these hereditary hematologic malignancies, and a question around the need for a certain level of white blood cell counts to actually do effective telomere testing. How do you address that situation?
Yeah. The telomere disorders are definitely some of the more challenging because there's a lot of gray in the diagnosis, in the sense that about a third of patients who have short telomeres, you don't actually identify what the underlying gene is, meaning there are some still to be identified and discovered. And so you really are relying on short telomeres for the diagnosis in about a third of your patients. And it's really hard sometimes to get reliable, CLIA validated telomere length testing. When the white count is low, because of chemotherapy, or really the effect of chemotherapy on the telomere length themselves hasn't really been validated. So the gold standard of doing flow FISH on, to get telomere length is in the peripheral blood of patients that have not received prior therapy. So we try, for the patients that are coming to our institution, to do that within the first week or two of their presentation, prior to them getting therapy that's dropping their count to make it, all that more challenging to get a reliable sample.
Yeah, I guess, I learned something every time Courtney talks about this, and I thought it was a great talk too. I guess with the telomere disorders, I think it's important to remember that people's telomeres get shorter as you age, and that we're not really sure what and it's been well established and published that people with shorter telomeres have worse outcomes with different therapies and transplant. So it's not really clear, how much of these are mutationally driven, germline mutationally driven, or just older telomeres that fare worse with chemotherapy. And it's a schmear, as Courtney said, a continuum. I do want to kind of point out a couple, and this looks like a mix of clinicians based on the questions and molecular pathologists and scientists on the line. But for the clinicians, one of the things to add to Courtney's slides on recommendations, two things, with regard to telomeres, if you have a young patient with MDS, young people shouldn't get MDS. So really all those people should have germline testing, at least for telomere disorders and chromosomal fragility. And that's, every institution will do a little bit differently, but I think, that should be in the first sets of things that you would order on these people. And I have had, a surprisingly high positive rate for those people. And of course, it's clinically important because you're not going to give ablative conditioning to a person with, chromosome fragility, and you could hurt them. And this could be a big difference in their outcome. The other thing I just wanted to add, going away from the telomere disorders, but just talking a little bit about recommendations, Courtney's a leukemia doctor and did a wonderful job talking about leukemia, germline predisposition. She did allude to MPN predispositions. One of the things that she really hit on was how important family history is, and she probably draws better pedigrees than I do. But the idea of thinking about the pedigree of potential MPN kindreds, always be asking about vascular disease. And everybody has vascular disease, but vascular disease in young people that pops up a lot, and families that might not have been able to diagnose, a JAK2 mutant in the 40s, 50s, 60s, 70s, but may have died of a heart attack age 30, non-obese. These are all clues that these people may have MPN germline-driven kindreds.
Thank you for that commentary. I wanted to also bring up the fact, we're all here together because we're raising awareness about these hereditary heme malignancies. But, there was one question we got from a participant stating that they're still struggling with raising awareness even in their own institution. And they're wondering, what quality of improvement initiatives and or education have you done at your own institution to really start to implement this kind of clinical workup? And maybe I'll start with you, Dr. DeZern, to comment on that.
I think it's a very fair question and something we all continue to struggle with. But I have found in our own experience here, the more it gets worked up, the more it gets worked up. And so we have protocols somewhat analogous to some of what Dr. DiNardo showed. And as Dr. Savona alluded to, we have age cutoffs. So there's a very protocolized approach to everyone who comes in with a new diagnosis of MDS under the age of 50. They do get telomere link testing. They get Fanconi testing, however you do it, and a few other things. The skin biopsy for us is usually a second step, but that's another point of awareness where we engage other people. And I think a lot of multifactorial grand rounds, these type of approaches really do raise awareness, because I saw another thoughtful question about someone talking about the NCCN guidelines for hereditary breast and ovarian cancers. And I'll just tell you the truth, on the NCCN MDS panel, we borrowed from their guidelines to make our MDS guidelines, because solid tumors can teach us and vice versa. I don't know if others have other comments.
Yeah, I will say, just on a more broad scope in terms of raising awareness on a more international scale, there are updated guidelines coming through for several different, working groups, ELN, WHO, things of that sort, that really are going to have, over the next 6 months to a year, kind of more granular and better recommendations for germline evaluation. So that will be helpful, I think.
And
For me, it's go ahead.
I was just going to say, I would stress that it's a simple thing like, sharing the slides from today with the fellows that are at your institution and your pathologist. I think these are fast. Courtney did a great job of summarizing things, but the cases that were presented, I mean, those are things most of us would have missed, let's be honest. And, in a place that's really resource rich, is an opportunity to do, whole germline sequencing or whole genome sequencing and find these things. And now we're it's still evolving how we do that in the market and how that gets paid for. And, but at least we know that's a thing. Where before we said, oh, well, the RUNX1 testing was negative, so that means they're negative. Well, it may not mean. And now we can be thinking about this. And it's a good way to kind of grow our brains on how we're thinking about germline testing, I think.
Absolutely. What about the role of of genetic counselors, and what if you're at an institution where you don't even have access to a genetic counselor? What should folks be doing or thinking about or considering?
I think it would be really hard to do this without a motivated and invested genetic counselor. I mean, they are so key to everything that we're doing here at MD Anderson. You could identify patients or family members of interest, but the whole kind of referral and having time to sit down and kind of go through a pedigree and to go over the kind of risks and benefits of genetic counseling and testing. And Kevy, who's the genetic counselor who works with me in clinic now, spends about an hour with each patient, and that's time that I unfortunately just don't have to spend counseling patients in a clinic. And so I really, and they're very good also at helping to provide letters that go to the family. We've identified this, give this to your other family members so they understand what to ask for when they seek out genetic, testing of their own. And so they really are a very key resource.
Yeah, I can't underscore that enough. And hopefully my administration is listening, as is everyone else's, because, this is becoming more of a complaint I hear when I'm talking to colleagues around the country is, hey, we don't have those resources. And obviously, Kevy gives a lot of value to Courtney's clinic and really has made this, look what she's built in the last 7 or 8 years here. It's tremendous. But I wouldn't want that to dissuade you from not taking some of this on in a smaller way. There are bits and pieces that you can do. There is time that you do have. We've built up a couple of tumor board opportunities locally here. We have engaged with junior faculty who are kind of making a career out of this. There are ways to grow this in bits and pieces, but clearly to take that kind of volume, you just can't do this without genetic counselors. It's very true.
Yeah, absolutely. Well, thank you.
I'm just going to interrupt real quick. So Sarah Bannon just sent a chat. I don't know if everyone can see it, but she was actually the genetic counselor who helped me establish the hereditary clinic in the first place. We worked together for several years before she moved to a telegenetic counseling company. And so there are services like this that are fantastic, that if you don't have your own genetic counselor, you can refer patients to kind of virtual telemedicine consultations.
That's a great point.
It's fantastic.
It's a very good
for
point.
A lot of the family members we've had that can't come to Texas, we've referred them to Sarah, on a virtual scale.
And I believe there are even some of these companies who are doing the sequencing that can offer genetic counseling support as well. As a follow-up to this webinar, we will provide a list of companies that provide germline testing so that it's a resource to those who are interested in really implementing this in their own clinics. There's a lot of really specific questions, and forgive me, we're not going to be able to get to all of them, but I will start with one around transplant, which I thought was a good one, which is it standard of care for transplant AML and hematologic malignancy patients to undergo germline genetic testing at the transplant center? Yes or no?
No, short answer.
It's a fair point, though. So we try and be thoughtful in this regard. It's not standard because despite awareness, there are probably still the majority of patients who have a donor who, even though that donor has a first degree relative who has a heme malignancy, you need to know what the issue is with the patient before you know if you need to worry about that in the potential donor. But there are algorithms about age of donor, what's going on in the patient, and how we need to screen a related donor to make sure they're safe to use to avoid some of these issues. It's a much broader discussion because it can be complicated, but to send telomeres or something like that on every potential donor is not standard.
Mm-hmm.
I think that, as Courtney pointed out really well, there are, it's this variable penetrance of these, with these syndromes. And, some of the times the patient's really hurting for a donor, and, with a low penetrant kind of mutation and, not a lot of family history, you're not going to do much with the result. You're just going to cause angst with the result of the mutation. But there are certainly some that, this would cause you to choose another donor, an even less desirable donor, by HLA matching or so forth, or CMV status, if the mutation exists. So I think, no, it's not standard, but the answer is, when we do it, it depends.
Mm-hmm. Yeah, that makes sense, especially with regard to penetrance of some of these genes or gene mutations. What about keeping track of family members after a germline mutation has been identified and you've got at-risk family members? What do you do? Maybe I'll start with Dr. DeZern.
Well, this will sound silly, but I keep as pedantic of a social history and family history as I can in patients who I'm suspecting of it. And I try and keep it going forward through my notes, because as the patient ages, the family members age and may become of childbearing potential or already are, and things like that. And I try at each visit with the patient to inquire if any family members have decided they would like to learn about it. Just the other day, I had a family member whose sibling had not originally wanted to know and had become old enough that now he was ready to sort of absorb information one way or another. And so we have a visit in the future to review what the patient and I have known for a long time.
Great. Dr. DiNardo, you look like you wanted to comment.
No, that's one of the things that that Kevin, the genetic counselor working with me, has done a really great job of, because someone also mentioned a comment about variants of uncertain significance, and in heme malignancy, where we're still annotating a lot of these genes, we're getting a lot of variants of uncertain significance, and I feel like it's very different than getting a BRCA1 or BRCA2 variant right now, which is most likely to be benign. Variants in genes that we haven't fully annotated really could go either way. And so, keeping track of patients and family members, not only for that, but for the iterative changing and assessments of specific variants that we identify is important.
That's such a good point, because I know, at least in the RUNX1 community, there are over 300, I think 350 variants of unknown significance. And so we think, oh my gosh, that's potentially 350 families walking around that could have a disease, and we just don't know yet. So very, very good point. It's 2:01, so we're a minute after. I want to thank you, of course, Dr. DiNardo, but also Dr. Savona and Dr. DeZern for joining us in this panel discussion. I wish we actually made more time for the panel discussion, because there's a lot of really good questions. We're going to copy all these questions and we'll get back to you. and send some answers maybe through an email blast to all of our registrants. So thank you so much for joining. We'll provide the recording, and just to quote Dr. DiNardo, if you pay attention, you'll find more and more of these patients and their families. So pay attention. All right, thank you all. Actually joining us, we have 3 more experts from around the country, and I'd like to introduce them. We have Dr. Kelly Bolton from Washington University School of Medicine. We have Dr. Elizabeth Griffiths from Roswell Park Comprehensive Cancer Center. And we have Dr. Yasmin Abaza of Northwestern School of Medicine. And they're all going to join us and give their perspectives on some of the questions that we've received from all of you, so that we can get different angles, different approaches, and different thoughts. So I'm going to start with a fairly basic question. Lots of great questions. Please continue to input your questions through the Q&A. The first question that caught my attention was, do you recommend testing a patient who has not been diagnosed with any MDS or leukemia, but has a very strong family history of leukemia? And it's a little hard to imagine how that patient might arrive in the office of a hem-onc, but curious if that has happened for any of you.
I mean, it certainly happens. We'll have family members, healthy individuals that come to seek out genetic testing, just as any young healthy person would seek out hereditary testing for a family history of breast cancer or GI malignancies. If possible, the best person to test is a patient that actually has the cancer in question, right? So because that is going to tell you what is potentially running through the family. If you find an inherited mutation in the dad who had the leukemia, then you know what to be testing various healthy family members for. Because since our field is so new, if you do testing of a healthy individual and you don't find any mutations, that's reassuring, but it doesn't totally answer the question of, have you identified what could have been running through the family. So that the index patient is always the best, if possible.
Makes sense. Any other comments from any of the other panelists on that? All right. Another question we got was, how frequently are you doing somatic mutation testing on your patients with MDS and or AML? What percent? So is it 90%, 100%? And then how often do you find yourself catching some of these mutations that are potentially hereditary?
Kelly Bolton is probably the best to answer this question in terms of true percentages. We certainly test everyone coming to MD Anderson with MDS or AML or any sort of myeloid disorder. We do panel testing, and then we try to follow that over time as well. Insurance sometimes doesn't pay for the follow-up, but for the presenting patient, almost always. In terms of how frequently they will have something that's flagged, I'd be interested to hear what other people say. But I showed my list of genes. I would say probably, I don't know, 15 to 20% of the time, a patient will have one of those mutations that we have to go back and think through and say, should that patient be referred or not?
Yeah, I agree, Courtney, because there's a lot of the common genes that are somatic drivers are concern for germline, like TB53, yeah. Or things like that. And so with this, we're just starting to do this now actually at WashU, and we didn't really do it at MSK at all, this reflex testing. But it creates some work for everyone, because like Courtney was saying, there's a large volume of individuals that you have to then reflex to, but it does help, like Courtney was saying in her presentation, having multiple time points. That's a very, very helpful thing. And it's feasible to do this reflex testing. I shouldn't scare people from doing it. It's feasible, but it does add some, about I'd say a fourth or a fifth of people we end up having to do a little more digging.
Maybe you could expand a little bit on, the work and how in practice can you sort of solve for some of that? What kind of providers, what does your group and your team look like to help you take on that work?
Do you want me to answer it, Courtney, or do you want to?
Sure, go ahead. Yeah.
So the first thing, I guess, is to decide whether you think something is potentially pathogenic or not, because you're gonna flag variants that are based on the frequency of the variant in the general population, and what you know about the biology of the gene, like is it a tumor suppressor gene or is it an oncogene? And so then when you have your list of candidates, then you would then the next step would be to say, well, are these genes known to be relevant to germline predisposition? And then if the variant is significant and the gene is relevant, then you would either, if you have sequential testing, you would try to use that. Or if you knew the patient was about to go into transplant, or, then you would maybe wait for the remission sample. But if not, you could do skin biopsy and fibroblast culture from that. You can do that both in-house some places, and then if you don't have that, there's commercial groups that will offer that. Like Invitae now offers that for a very low out-of-pocket fee if insurance doesn't cover it.
And is that, do all of you practice using skin punch biopsy? Do you use any other germline tissue?
I can answer that. We routinely do skin punch biopsies on our patients when we're concerned about the potential for a germline predisposition syndrome, and we have the option to either expand fibroblasts in-house or to send the sample out to Invitae or to other commercial vendors to do that. We've collaborated a fair amount with the University of Chicago for their testing.
Great, thank you. There's a couple of questions on preferred labs to send DEB Fanconi anemia testing and telomere studies to. Are there preferred labs, or maybe some of you could comment on how you manage that? And there was actually also a follow-up question with regards to whether for that testing you could just use blood, or should a skin punch biopsy be used for that kind of testing as well?
You don't have to do DEB. So DEB or mitomycin C are both clastogen assays that you can do for Fanconi, and either of them are fine. And that's a pretty standard send out. So that one's not so challenging. We send ours through Mayo Clinic, I think, and we get results back pretty quickly. The telomere flowfish is a little more challenging. There's two places in North America that are CLIA approved, Johns Hopkins and Repeat Diagnostics, which is in Vancouver. And so at MD Anderson, because Vancouver is ex-US and an international site, we can't send to them. And so we do our telomere flowfish through Johns Hopkins. And we do peripheral blood typically for these tests. There is a instance, relatively small, probably 5% or so or less, of somatic reversion for Fanconi anemia. So if you have kind of a family history or something super striking, and you think a patient really does have Fanconi, but yet you're only, the peripheral blood testing is negative, you can follow up and do a skin punch to confirm.
There was actually another question, again, going back to this whole skin punch biopsy process and fitting it into the workflow. Given that, what do you typically see as the turnaround time? Because some folks are asking about the time it takes, and is there a way that you've been able to triage newly diagnosed AML patients, for example, to sort of address that as quickly as possible? If any of you want to comment on that. Maybe Dr.
Yeah,
Abaza?
Go ahead, Dr. Abaza.
Sorry, can you hear me? I'm sorry, I'm having technical issues on my end.
We can hear you.
Okay,
You're a little
great.
bit soft-spoken, but we can hear you.
Thank you, I'm having issues. Is that is the question for germline testing?
Yeah, using the skin punch biopsy, how do you try to implement a process that you can do this quickly?
So it depends. So sometimes depends on insurance. We very rarely can get it done in-house. Mostly it's done outpatient. I've rarely be able to do it in the hospital. It gets blocked multiple times. So most of the times we're able to do it only in the outpatient setting. It has to be, as you said, through a skin punch biopsy, and at least internally, like from for at Northwestern, it takes about 4 to 6 weeks for us to get results back. So it takes closer to 6 weeks. And it doesn't hold us from going to transplant because most for these patients, we go with unrelated donors anyway, but we would like to have that information on hand. So we do it and we send it out, and I have a patient like that now, and he's going for an unrelated donor transplant. So we still proceed with treatment as is, but we do the testing once we see the patient in the clinic.
Great.
I'll just tag on to that real quick, because I think it's an important point, right? You know, when you do testing on skin punch biopsies, it takes longer than peripheral blood. You know, if you rush it and you're lucky, it's, 4 to 6 weeks, but oftentimes it's like 8 weeks. And that can be a really long time if you're getting a call from a transplanter saying, I've got the brother here and I want to go to a transplant in 2 weeks, but I'm concerned there's something running in the family. Can you see them quickly? And I'm like, yes, I can see them quickly, but the testing is going to take a little bit, to do it the right way and to, test the index. So ideally you have a workflow where when a patient is first referred to you, or to your institution as a whole, to anyone involved in hematologic malignancies, is there a family history? Is this patient, 30 with a new MDS diagnosis? Should this patient be referred? Because the sooner you do that, the sooner testing is started, so that you're not feeling crunched for time, when you're trying to be moving to transplant.
Yeah, that's helpful. 8 weeks. I didn't realize it can be that long. That's significant.
Mm-hmm.
There's actually another question. Oh, go ahead, Dr. Griffiths.
I'd just like to make a comment. I think one of the things that this highlights is the importance of identifying patients with a strong family history at the time that you originally see them for the new diagnosis, and then making it a practice to have those patients seen by the genetics counselors and evaluated during the course of their hospital stay. So what we often will do is we will often have them seen by the genetics counselors and to have the skin biopsy sent. And even if you can't do the testing at the time that the patient's in the hospital, you can send, if you have the luxury like we do of having potential in-house expansion of the fibroblasts, you can do the in-house expansion of the fibroblasts and send the testing on the expanded fibroblasts, because the fibroblasts can take 2 or 3 weeks to grow. And so we would do the testing at the time that we do the day 14 bone marrow, because usually we don't realize that the patient is going, we don't necessarily know right away. And so we would do a skin biopsy at the time that we do the day 14 marrow, and one can just do that right at the spot where you do the bone marrow sample itself. And that way you don't have to include an additional team. The other option is to call the dermatologist and have them do the skin biopsy for you. Just from a practical perspective, it's often, we always wonder, like, what are we going to do? How are we going to get this done? And I think that's from a practical perspective, to just do the sample at the time of the bone marrow biopsy. You're already numbing, you're already taking the biopsy. You can just either use a skin punch biopsy at the site of the bone marrow, or you could use the knife that you use to do the skin incision and take a small piece of skin and put it into media. And that's what we do routinely for our patients where we are worried about an inherited predisposition syndrome, to get that cultured fibroblast process going earlier.
That's interesting. I mean, do you ever envision, would it ever make sense, given the prevalence of these hereditary malignancies being as high as 15%, and knowing that the pace of discovery of some of these new genes, it just seems to increase over time, maybe that prevalence is going to be even greater than 15%. Do you envision a time where maybe it just makes sense to take that skin punch biopsy for every patient, and so then you just have at least a germline tissue source for their handy, right, in the future? Do you think that that's something that would make sense?
I think that would be a great option for people. The problem is that these cultures take a lot of space in the fridge, in the incubator, and they require a fair amount of technical expertise for the expansion. So in terms of cost, that's something we would have to work into. But I do think in an idealized circumstance, a biopsy taken at that early time point and expanded for skin fibroblasts would be a great source of germline tissue for future testing. And I think if we can move the field for people to at least recognize this, then we can perhaps start to put that into place. But I think we have to prove that I think there are a couple of barriers to that. I think we're starting to get traction that this is really an important inherited predisposition syndrome area to look for. And I think then we have to prove to people that the skin fibroblast is the idealized source of germline tissue.
Mm-hmm.
And then we have to make sure that insurance companies and hospital systems recognize and validate that this is a useful and important place in which to invest money, which I think all these things are true, but we have to prove it, and we have to develop guidelines that support that.
Yeah, it takes time. So right now, lots of logistical barriers, it sounds like. There's another question specifically around Li-Fraumeni or Lynch syndrome, for example, and whether you would feel comfortable on using a sibling donor if they have a solid tumor predisposition like Lynch syndrome for a leukemia patient. Any comments from any of you on that question, that very specific question?
I think we were all silent on answering that question because it's a tough one. So if you had asked me about kind of a breast tumor predisposition, even a couple of years ago, I would have said, it's probably okay to use a patient with a germline CHEK2 mutation. But now, we're realizing that germline CHEK2 mutations actually lead to an increased risk of hematologic malignancies. So my answer for that, has changed, I think, over the past few years as we've learned more. So, I think my current, anecdotal answer is that I would prioritize a fully matched unrelated donor over a family member who has a cancer predisposition syndrome, kind of period, regardless of what that specific cancer predisposition is, just because there's such a, when you're getting a transplant, you are starting and you have these stem cells that are rapidly, trying to repopulate an entire marrow. So you are putting so much stress on these cells that, if there is kind of a predisposition, I worry that might not be the best option if there is an equally good or unrelated option.
And what about potential risk to the donor as well, if they have the predisposition of some sort?
In terms of giving them, Neupogen to stimulate, I think we've done a lot of studies looking at kind of risks of donors, and so I wouldn't be so concerned about that as the issue as what would happen in the donor cells as they expand in the patient,
in the recipient.
Yeah.
Great. The other question that we get a lot is a question around, if you don't have the resources that some of you have, within your institutions, how can you sort of navigate, what can you do around putting some of this clinical workup and this workup flow within your own clinic that may not have a genetic counselor, or what are some recommendations, or how would you kind of work through that? Or do you recommend that, maybe the best thing to do is just know how to suspect and think about what tests to order, but then think about referring to an institution that is, has the resources? I'm just.
Yeah, no, I think, one of the silver linings of the pandemic, right, has been telemedicine. So there are now, telegenetic health options. And actually the genetic counselor who used to work with me, and helped me set up the hereditary heme malignancy clinic here, now works for one of those companies. And so when we have, family members that live in other states, or people that want to come that their insurance doesn't approve MD Anderson or certain other places, actually they can have, at least an initial counseling session, and then they can help coordinate testing and get them to a place where, so I don't know that that's necessarily the optimal thing for everyone, but if you were at a place where you really can't organize, or you don't have a counselor that works with you, and you want, that patient to have, that, and a full pedigree analysis, 45-minute counseling session, which can be, patients really appreciate that, that would be something to consider.
Great.
Yeah, and I'll also add maybe that there's really good, or there increasingly maybe there's good commercial options for germline testing, where the company actually does all the billing and prior authorization in regards to insurance for you. So that's a big barrier for some institutions and some practitioners. And so using one of those providers, while the panels might not be as expansive as maybe some people would want, it was a good solution.
Yeah,
I'm
that's
thinking you guys are going to provide a list of
that just reminded me that we will provide a list of resources, at least of those labs, commercial and academic, that do offer germline testing. So we will provide that to the registrants after this. I know we're 1 minute over, and so there's a couple more questions. I know Dr. DiNardo, you mentioned you'd be willing to stay for a little bit of extra time. The rest of you, Dr. Bolton, Dr. Abaza, and Dr. Griffiths, if you need to go, I completely understand. But if you want to stay on for a few more questions, we'd welcome that. There's a specific question around PAX5 and IKZF1. So these are mutations that predispose to T-cell leukemias, specifically, and mostly in the pediatric setting. But there's a question whether we're seeing that in the adult setting as well, if there's any new findings around those particular mutations.
I don't know if anyone else has an answer to that. I have yet to see a PAX5 family. And so I think, I don't see as many pediatric patients. We do sometimes, but it's mostly an adult clinic that I run here. We have actually some adults with ALL, familial ALL with IKZF1. And so, but few, two I can think of in the 10 years or so I've been doing this, 8 years.
I also wanted to ask a question around which came through in some of the more specific questions, but just the idea that some of the variants you might be catching on germline testing are VUSs, and how do you manage a patient when you identify a VUS? But there's clear indicators that there's a family history or something that makes you really cause you to suspect that there is something going on here.
I think this is where our opinions, I think as leukemia physicians, differ a lot from the genetic counselors. And so if they're on the phone right now, they may disagree with me. But I think, when you think about breast and ovarian cancer syndromes and Lynch syndrome, we've annotated those genes for decades. And so the VUSs that we find there, we know are more likely than not, the VUSs are going to end up over time being benign or reclassified as benign or likely benign. Whereas in our world, where we really haven't fully annotated a lot of these genes yet, we get a lot of variants of uncertain significance because we just don't have the knowledge yet to know where they fit. And so I do feel like many of them may end up becoming reclassified as pathogenic or likely pathogenic, with more time or with the family studies that are submitted. And so as you can't take a VUS and without additional studies say that this is what is running through the family and this is the cause, but I'm always kind of cautious in how I counsel them, and I try the best I can to keep track of these patients and families so that when a VUS is reclassified, we can reach out and say, hey, this is or is not disease causing as far as we know.
Dr. Griffiths, are you also tracking your VUS patients?
Yeah, so it's very hard. What I try to do is I try to refer my patients to genetic counseling and then have them go back to be seen again in follow-up on a yearly basis if we find people with either a VUS or nothing identified. The other thing that I have done is I actually opened a study here as a second site based in Chicago, at the University of Chicago. Lucy Godley has an inherited predisposition bank registry that she has, which allows us to enroll patients prospectively to give leftover skin fibroblast or germline tissue and leftover sample of bone marrow and blood, or prospectively follow those patients. And those people also have their pedigrees recorded. And so if that's an option, participating in one of these registries, I think, is an ideal way to collect the samples. And that study particularly is lovely because it allows us to go back and inform patients of results that come later. And I think, unfortunately, that's really the only way I think that you can make sure that you keep people involved, because once somebody has had a transplant, if they're in remission and doing well, you may not end up seeing them as regularly, or people may move. And so I think participation in registries where you have a strong family history is critical.
Yeah, thank you for that. I wholeheartedly agree. Research is so important and is really the only way we're going to get some answers to some of these really important questions. So great to hear that that's available to anyone, really. If your patient is interested in participating, there are registries. And in fact, there's I should comment, there's a natural history study being run by the NIH on RUNX1 FPD as well. So you should be aware of that as well if you're on the call and listening. Well, I think that really covers most of the really key questions. And I just want to again thank you, Dr. DiNardo, Dr. Griffiths, Dr. Abaza, and of course we lost Dr. Bolton due to going over. But thank you all so much. Really appreciate you sharing your wisdom and knowledge with the audience today. And we'll share the webinar with all of you registrants. And I just want to close with saying that remember, if you, I think this was Dr. DiNardo's quote, if you start looking, you'll actually find more and more of these patients, and it's really critical. And all the at-risk family members need to be carefully surveilled. So please do remember that this is an important new area and important to patients and their outcomes. So with that, thank you all, and have a good rest of your day. With us today are two experts in the field as well, alongside Dr. DiNardo. We have Dr. Eric Padron, who is the scientific director of the Department of Malignant Hematology at Moffitt Cancer Center. And then we also have Dr. Srinivas Tantravahi, from the associate professor from the Huntsman Cancer Institute at the University of Utah School of Medicine. So this group is going to help us go through some really fantastic questions already. And if you haven't already submitted your question, please do through the Q&A icon, and we'll go through as many as we can. So I'm going to start with the very first one, and that was from someone who was asking about commercial laboratories, Invitae, Ambry, GeneDx, et cetera. And whether there are any recommendations from you all as to which have comprehensive hereditary heme panels, which maybe don't. And if this is something that you prefer not to answer, I do understand, because I know you can't promote any one commercial lab, but maybe you could at least help the audience think about what they should be looking out for, if you can't answer that directly.
Yeah, no, I mean, and I don't mind answering with what my experience is, but remember that my experience is based on where I work and what labs we're contracted with, right? So it really has a lot to do with where you practice and finding out where your samples can go. And for example, the University of Chicago has a phenomenal panel that I would recommend, but MD Anderson doesn't contract with the University of Chicago, so I can't send them there. And so I send samples either to GeneDx or Invitae, because those are the two that I'm contracted with that will culture skin fibroblasts, which I'm doing in many of the patients that I'm sending out for. Many of the other labs are great, but just don't have the ability to, in a clinical setting, culture the skin fibroblasts, isolate the DNA, and then do the testing.
Any other comments from you all, Dr. Padron or Tantravahi?
Yeah, just to build on what Dr. DiNardo said, we are in fact able to contract with the University of Chicago, and so we send ours to them, and it's been great. But I would emphasize, as Courtney did in her talk, that probably the most important thing is not what commercial lab you send it to, but what tissue source send them, and are they able to do that? So that would be my litmus test.
Great. All right, I will move on to the next question. Dr. DiNardo, excellent talk. I would like to know, which algorithm do you follow in your clinic with regard to thrombocytopenic patients? Which of them do you test for RUNX1? Are there other triggers like corticoid steroid refractory, chronic? Are there chronic cases? Like how long have they been dealing with thrombocytopenia, for example? How do you rule out, and when do you decide to offer that genetic test?
Yeah, I mean, I might actually punt this question to either Eric or Srinivas, because in general, I'm assuming this question is based on, you have a patient without a myeloid malignancy who has kind of a long-standing thrombocytopenia, and that's actually not something I see at MD Anderson, which is a standalone cancer center. Patients are primarily coming to me with MDS or AML, and they'll have a RUNX1 mutation, and so I'm trying to figure out, is it germline or somatic, right? So this is a slightly different question. And so my interpretation would be, I would imagine if a patient had a family history of thrombocytopenia or had, kind of persistent, kind of aspirin-like platelet deficits where, it's just a mild thrombocytopenia, but yet there's kind of a bleeding phenotype out of proportion. Those are the kind of indications for me that an inherited thrombocytopenia workup, which includes RUNX1 as well as other genes, should be included.
Yeah, I can share my experience since I treat some of the ITP patients as well.
Yeah.
I think the question is referring to is how do I distinguish between ITP versus a familial thrombocytopenia? So in majority of the patients with ITP, they do present with severe thrombocytopenia with bleeding symptoms. Often the platelet count is less than 20. So, and it's an isolated abnormality and rest of the blood counts are normal. So those can be sometimes sort of, even though it's a diagnosis of exclusion, but can be easily identified and also response to steroids. But what I also see is that, that as Dr. DiNardo mentioned, is that there are these patients with mild thrombocytopenia. We see them a lot in the clinic, and that's a major challenge, who you want to test and who requires these more careful evaluation. There's definitely a clinical judgment call in there based on family history, their bleeding symptoms, and also what's the index of suspicion for germline, like a familial thrombocytopenia.
I'm curious.
Again, there's no specific test either to send to, so that's also makes it challenging. Some labs do have a familial thrombocytopenia panel, but more genes are being added to that list.
Yeah, quite regularly. My follow-up, thank you for that. My follow-up question would be whether you have any challenges as actually getting those tests covered by insurance, or is that fairly easy?
Yeah, so I mean, I guess that also ties to the first question, to which lab do you prefer? My own personal experience is none of these labs are comprehensive. So there's no particular preferred lab we have to work with based on the insurance and expected out-of-pocket costs and stuff like that. There's some personalization, but the Invitae has a familial thrombocytopenia a test which is fairly comprehensive, and I've used it on select patients. But I must say we've identified some of our particularly familial platelet disorder with RUNX1 is by doing a somatic panel that we normally do in myeloid malignancies patients. So we often use that as a as Dr. DiNardo mentioned in the talk, that if you see a VAF close to 40 to 50%, then there is a high level of suspicion for germline, and then we'll test in the skin fibroblasts to confirm the germline nature.
Yeah, great. Well, thank you. I'll move on to the next question, which is around, oops, sorry, it just moved. And Dr. DiNardo, you did cover this a little bit, the fact that there is no real strong consensus about surveillance protocols, but there is a specific question around unaffected carriers for DDX41 and whether there's any more, maybe more specific surveillance for those carriers.
Yeah, I mean, I would consider them, in the same group as others with
various different inherited primarily myeloid predispositions, and agree. It is, expert recommendation at this point, although I will say that we just published an updated ELN, the European Leukemia Net, which does have a section now on inherited predispositions and has some, again, expert opinion, but it's now kind of formalized a bit more, which essentially is lab work twice, like Q6 months, with a baseline bone marrow, just to get a sense of what that patient's like normal baseline actually is. And then, I offer ongoing surveillance marrows in interested patients on a research basis only. There's really no clear evidence that that's going to be a helpful thing to do, unless there's changes in the count. So I'm monitoring the counts every 6 months, and then only doing additional bone marrows, in the setting of changes.
Great, thank you. Dr. Padron or Dr. T, anything you want to add to that in terms of surveillance? Anything specific you might be doing with DDX41?
Yeah, one thing with DDX41 that's kind of challenging is these, especially patients with MDS AML with DDX41, they're extremely difficult to distinguish from sporadic MDS AML because the presentation is often in the 5th or 6th decade. So in our experience, we've investigated sometimes young people, if that we identified unaffected carriers is because they could potentially be a donor for either a sibling or a parent for a haplo. So those individuals in their 20s who we identify a DDX41 is very challenging, and you're potentially looking at 30 years of surveillance if you really do. So I think there's definitely a challenge there. We did do some baseline blood counts in some patients, but again, no formal recommendation. The other challenge with these young people is even though there's no sort of medical insurance wise not a big issue, but sometimes they may face trouble with getting life insurance if this considered as a pre-existing condition.
Yeah, absolutely. I can say that our patient population certainly was, our families certainly struggle with that question around, well, maybe I don't want to actually get tested. I know some of my family members have this, but do I want to do that? Will that affect my chances at having life insurance? So completely understand that concern.
And that's why you want a good genetic counselor working with you, because that's part of what they do, right? They go through and they, discuss in pretty good detail with the patients or, the family members under evaluation, to figure out, is now the right time to undergo testing? Because, as was mentioned, we can't discriminate for medical insurance or for job security, but certainly life insurance doesn't have those same rules. And so, one of the things that, our genetic counselors make sure to tell patients is, if you have, if this is not an urgent test that needs to be done immediately and you don't have life insurance in place, that's something you may want to get before you proceed with testing.
Oh, that's really a great idea.
Yeah.
I wanted to move on to the next question. We've got lots of great questions. The next one is around in context, in line with when you were showing the data around TP53 mutations and following them serially, and then picking up on the fact, well, wait a second, this variant in low frequency is stable. We might have something here. And this is from a genetic counselor who's saying, well, is this pretty common now to be able to do this kind of sequential molecular profiling? Can it be covered, et cetera? Because that seems like a great way to catch some of these patients.
Yes, I would say the majority of and MD Anderson is a unusual cancer center, I would say, where people typically have, outstanding insurance, when they're coming in my door. So I have a biased kind of US population. So I don't have challenges. I don't know if that's the same experience that, others on the call have had, but in general, more and more, following molecular testing is becoming an accepted, standardized, clearly, beneficial thing to do for a variety of different cancers. So I think, the insurance pushback that I used to see in patients where I was getting serial mutational testing a few years ago, I rarely will get those denials. And typically when I call, I can get them, overturned.
What about you, Dr. Padron? Are you experiencing the same?
Well, at Moffitt, we have a similar unique situation. So most people do have insurance, and the policy at our hospital is if they have insurance, the patient will be guaranteed that they pay $0 for our in-house sequencing test, which covers the majority of the inherited mutations that we talked about. So in that sense, no, I have not experienced that. In terms of how frequently I do it, so one of the things we have is a clonal hematopoiesis clinic, which is slightly different, right? That's where somatic mutations, not inherited mutations, are present. And in that case, it's although we still don't understand it well enough, to me, it's critical to monitor serially. I think P53 is a unique inherited mutation where there can be some value in it, but oftentimes, you know, for others, they're obviously very stable.
It all makes sense. Definitely another interesting evolution in the field with these chip clinics. All right, so we have another question, quite specific, but I think it's informative, and it gets to the question around how do you manage these variants of unknown significance? And in this question, it gets a little bit complex. So let me read it out. I have a patient who has a Fanconi anemia, of FACL variant, bone marrow through next generation sequencing testing done at Tempus. And it's been classified as a germline VUS, but also as a likely pathogenic and a pathogenic variant at different labs per ClinVar. What is the best next step if considering Fanconi anemia? There is a case study which showed patients with the same mutation and another with very limited features as an adult. So lots of questions about this very specific case, but I think it's an important topic around this whole VUS as well.
Well, thankfully, in the case of Fanconi anemia, there is a gold standard test that is not genetic testing, which is looking at either is a clastogen assay, so DEB assay or mitomycin C, and so you can order that testing, and so you can see if there is kind of increased DNA breakage and chromosomal breakage. And so that'll actually give you a sense of whether this patient actually has a DNA repair defect like Fanconi anemia. So thankfully, that is possible, and that's what I would do for this patient. If it's just, and remember also, Fanconi anemia is one of the few that's autosomal recessive, and so it's hard to tell in this question stem. But if it's just one Fanc variant, it actually doesn't matter if it's pathogenic or not, because you have the other functioning Fanc-L. And so it's only if this patient had two pathogenic mutations that you would have the phenotype.
That's right. I didn't even pick up on that they could just be heterozygous. Thank you. Any other comments on this question? I guess maybe I would like to segue a little bit about, when you have a heme malignancy patient and you do in fact end up picking up a variant allele frequency at around 50% in a germline predisposition gene, RUNX1, GATA2, whichever your favorite is, but the report says it's a VUS. What do you do? How do you manage that?
It's really hard because and I might have mentioned this, I can't remember if I did in my talk or not, but in the world of hereditary cancer genetics, in general, the recommendation is if you see a VUS, you really ignore it because you haven't proven pathogenicity, and it's not appropriate to assume that this is disease causing, because in the world of, for instance, like BRCA1 and 2, we know so much about the genes and they've been annotated so well that if you see a VUS, it's actually probably going to ultimately be classified as likely benign or benign. But in the world where we are of heme malignancies, where these genes haven't been as well annotated, I'm not so confident that a VUS is going to end up being reclassified as benign. Like it in my opinion, could easily go either way. And so it's just really challenging. You have to kind of try to inform the patient that like, we really don't, we have this mutation and it's inherited, but we don't know if it's disease causing, if it's just noise and a red herring, or if it's, associated with disease. So it gets really tricky, and it's hard for a lot of people to understand that. So I don't have a great, sometimes there's, a phenotype associated with disease. So if
I was
it's
just going to ask, if it comes along with
Phenotype,
lifelong thrombocytopenia and
right, in a RUNX1 patient and the various different family members, who have the same thrombocytopenia, all share the same variant. Well, then you submit it, and then it actually gets reclassified, right? So that would be super helpful information. But without the phenotype, it's really hard.
Yeah, I agree. Obviously, your clinical suspicion makes a difference. But at Moffitt, one of the things that we have, and perhaps at Huntsman and MD Anderson, they do as well, there's this precision medicine group. And these are just a group of people who are constantly reviewing our in-house and external tests, and focusing specifically on VUSs, taking a deeper dive than we can in the clinic. And I don't know, I would say about maybe 30% of the time they can tell us with some degree of certainty, whether that VUS is likely benign or pathogenic. It's still a huge problem, but I think it also highlights, the importance of having some patients be referred to a tertiary academic center.
I love that point. That's a really important point. I also want to highlight the point that Dr. DiNardo made, which was submitting. So if you have a patient or a family and they've been, their mutation is classified as a VUS, submit to ClinVar and make sure that it's, part of the process of being shared with the community, so that others can, if they pick up on this, could start to add to it for research purposes and the like. Okay, I know that we are 3 minutes over, and fortunately, most of you have said that you would be willing to stay a little bit longer. But I completely understand if you need to take off. And so maybe I should just first start by saying thank you. If you do have to leave, I really appreciate you being here, and I know the audience has been clearly as grateful as well. So I'm going to keep going, and then I promise to stop at 10 minutes after. The next question I have is really interesting as well. What do you recommend for mutations identified after transplant when a patient has 100% donor chimerism? Should the donor then be notified and followed? Is there guidance around this?
So we get this all the time. Our transplant doctors are ordering NGSs 30 days post-transplant, 120 days post-transplant, and we get this all the time. And I'll tell you, 80 to 90% of the time, these are benign, SNPs that happen to be present in the donor, and are at a variant allele frequency of 50%. And so, most of the time it's just a matter of reassurance to say, no, that's okay. I can think of several examples. In fact, kind of weirdly, over the last couple of years, we've had 3 patients, 2 of which were unrelated donors, who had a bona fide DDX41 mutation post-transplant. And it poses a lot of interesting questions, because we know that the latency for DDX41 is quite long. So if the patients ask me, well, does this mean I'm going to get leukemia again? Well, I don't know. If you're going to live another 70 years, maybe, or maybe the stress of the transplant, accelerates things even more. And so I think number one, is it benign, or is it pathogenic? And then number 2, if it is pathogenic, counseling is very difficult, because in that context, we don't know how those inherited syndromes are going to behave, or in a new host, for lack of a better term.
Yeah, I would just add, you have to kind of go back a little bit and look at what the consent of the donor is, because, you want to make sure that there's, that at your institution, you even have the luxury to contact that donor and talk to them about things, that
So there's some ethics and some appropriate regulatory concerns built, into that question. But, we can contact our donors and talk to them if we're concerned about something. Totally agree with Eric. A lot of them are benign variants or are like small chip clones like DNMT3A or something, not germline at all. But we're seeing a lot of things in donors that probably don't need to be communicated because we're really not sure if it means, anything of relevance. I just saw last week, there was this enormous concern about, a patient who had a P53 mutation that in retrospect had been at a high VAF and had a transplant from his brother, her brother, and that P53 mutation was still there after transplant at a high VUF. And we're like, oh my goodness, this is Leaf-Ramini and we missed it. And it was actually one of the rare P53 variants that are benign. It caused so much scare, concern, thousands of emails for a totally benign P53 variant. That when she finally came to see me in clinic, I was like, you know what? Don't worry, it's okay. We can ignore. So there's just an example to say there's just so much nuance, but we're going to see more and more of this because, as Eric said, our transplanters are now understanding, and realizing how informative mutational testing post-transplant can be. But we're seeing a lot of variations in the donor because they hadn't been assessed with genetic testing before the donation. So it's a great question.
This highlights the importance of counseling when we're doing genetic testing.
Yeah,
whether it's a somatic or with the germline testing, there's always ambiguity around VUS and pathogenic and not pathogenic. So a good genetic counselor as a part of the program is highly necessary to do this kind of work.
Absolutely. There's another question here around DDX41. Seems to be a big topic.
Mm-hmm.
And the question here is around how do you decide who to test for DDX41? Do you think that we're going to start doing panels on everyone? And I think this parlays into one of the statements you made, Dr. DiNardo, which was that you saw even in your own clinic that half of your DDX41 positive patients weren't even referred to you. And so I was curious about whether you suspect the reason for that is because just no family history was taken because they were older. And so that's sort of been the practice, or a couple questions there, but.
Yeah, so we are doing we have an in-house 81 gene myeloid panel, which includes DDX41. So any patient coming in the door that we are concerned may have MDS or a leukemia is getting that panel. So yes, we're testing. And so we're finding these DDX41 mutations at the onset of their referral to us. And yes, I think the majority of the DDX41 mutations we find are going to be germline in origin. And it's going to be one of the most common inherited mutations, right? Because 1 to 2% of our MDS and AML patients have DDX41 mutations. As Srinivas said, these are older patients that you wouldn't necessarily have thought were going to have an inherited predisposition. They may not have a lot of family history for that reason as well. I missed the other part of your question, but I'll open it up to Eric and Srinivas if they have additional thoughts.
Yeah, that's exactly how we are identifying, because we added the gene to the panel. And what is interesting is that since we added the gene to the panel fairly recently, even the previously diagnosed patients who had a follow-up testing as, post-remission follow-up, now being identified as DDX41. And they may have had transplant with a sibling donor. So that's causing more, concern, because in the past we didn't know because we never tested these patients. And then, the other way we're identifying is obviously as a part of donor evaluation, especially if you're considering a sibling donor transplant, we're testing their unaffected family members, either children for a haplo or the siblings. And that's also another opens a big debates of how to counsel, how to follow up these patients. Obviously, we are avoiding them as a donor if a sibling, even though they're a match, but they have a positive mutation. So within our clinic, when we started formally testing these patients, we've identified, I think, 3 patients who would have had a sibling donor transplant. We weren't actually tested them. So we went with an unrelated donor transplant in that situation to just avoid this whole donor-derived leukemia problem.
Unfortunately, the unrelated donor transplants are now almost equally as successful, right? There isn't too much difference now, which is great, and definitely provides another option and alternative for hereditary heme malignancy patients. So,
yeah, I mean, it's not a negative. I don't feel like you're taking a step down or, impacting outcomes, but it can be a challenge if you identify it kind of as the patient is a couple of weeks away from a transplant, because then you're saying, oh gosh, hold on, let's reconsider this. Should we be using a different donor? And so it can get really stressful for, for the patient, for family members, so just a kind of a call to, get the referrals in and be thinking about these like at diagnosis. Because it can get a little bit challenging when you're trying to really, quickly rush, testing on family members, and then they feel a little bit like coerced, and we want to make sure that that's never the case.
Absolutely. Yeah, that would be.
Early referral is key. We've had situations where we get a call, we're transplanting next week.
Yeah.
Are you okay with that? I'm like, well, I can't tell you within a week whether the sibling has the DDX41 or not.
Yeah.
So we do need this at the time of diagnosis when a transplant is a part of the treatment plan.
Yeah, absolutely. Also demonstrates the need to hopefully identify as many people before they're even in the situation of having a malignancy, so that you can already have everything set up and know who, have a plan in place.
That's right.
With that, I'm going to close the session. I appreciate you, Dr. DiNardo, for this wonderful presentation, and thank you, Dr. Padron and Dr. T for joining and being a part of the part of this discussion. There are still more questions, and we're going to take those offline and try to answer those via email. We'll also be sharing the recording to all of you that joined us, but also the registrants who maybe couldn't make it last minute. And then I didn't mention when we were talking about genetic sequencing companies and what's available in terms of who's doing germline testing, we do have a resource available with all the companies that are doing this kind of testing. So we will send that out as well. And hopefully that's helpful to genetic counselors and physicians alike. And with that, I'll close this, and thank you again. Have a good rest of your evening. Before we get into the Q&A, I want to introduce 2 other expert panelists that are here with us to discuss some of these questions. So joining us is Dr. Stephanie Helene from Yale Cancer Center at the University of Yale School of Medicine. She's Associate Professor of Hematology there. And then we also have Dr. Shravanti Rangaraju, Assistant Professor at O'Neill Comprehensive Cancer Center at the University of Alabama, Birmingham. So welcome. Thank you so much for joining. All right, so with that, I'm gonna start with a couple of questions that we've received. One in particular was actually one of the questions that I had as well, which is, this is complex. You identify some of these germline, underlying germline mutations, but when do you decide on when to offer a transplant? And so there was one example given in the question, and I have some others as well. But the one in the example in the question is as follows. We have a 38-year-old female with a history of mild anemia and infertility, and her reproductive endocrinologist found 2 FANK-A deletions. Her bone marrow biopsy was normal, and her radiologist sees no signs of Fanconi anemia. Her hem-onc is curious about when should she be considering a bone marrow transplant. And I think maybe I'll add to that. There are other situations, and you mentioned one, for example, one case, it was a 53-year-old man who had a telomeropathy, had MDS, and was doing well on AZA, but you commented that you think eventually he's going to need a transplant. And so maybe you could talk a little bit about what that trigger point is. And then I'd love to ask the others as well how they think through this.
Yeah, I mean, it's a really big question, right? That you can answer, I could over the course of an hour kind of going through different specifics, but I would say, some of it comes down to the likelihood that any particular predisposition is going to develop into a hematologic malignancy. So when you think about like GATA2, for example, they have a 90% or so or higher chance of developing an ultimate myeloid malignancy. So that patient is almost certainly going to end up needing to go to a transplant. RUNX1, based on the knowledge that we have, is maybe like a 30 to 40% chance overall of patients developing an ultimate myeloid malignancy. And so some of it has to do with just the underlying biology of that particular disease. And also kind of course, like age and comorbidities and things of the patient. Most patients with Fanconi, Fanconi anemia are going to end up needing a transplant because they will develop bone marrow failure or requiring multiple transfusions, or will ultimately develop an MDS AML. So that patient, I think, should absolutely be getting plugged into, a pediatric transplant center where they are being evaluated, because I think, at some point, probably fairly soon, that patient may be needing a transplant. But I'd be very interested in hearing kind of what Stephanie and Sravanti have to say.
Happy to chime in. I mean, I would agree. That's right. It's such a major change in in a patient or person's life that nobody would take that lightly. But I think it's always good to really have patients evaluated early by a transplanter, and do all the possible validation testing so that you don't miss a time, but you also don't jump into a life-altering treatment, for example, especially in somebody who is seen for infertility, obviously seems to be wishing to have to build a family. So it's very complicated.
Yeah, I think that's exactly right. I think that timing, referral for transplantation and evaluation doesn't necessarily mean that we're going straight into transplant, but I think, kind of educating your family, the patients about it early on is kind of key, because they might need to be transplanted later on or decide to go up front. I think it really just depends. But I think this is not something that happens in one discussion, but takes sort of several discussions with patients, and the earlier we start, the better.
I think that's well said, that it really is this decision making between patient and provider, and talking through all of the potential complications as well, right, with making a life altering decision, and that you described, Dr. Helena. Thank you for that. So another question we're receiving, and I want to dig into this a little bit. There was a question around, would you recommend limited gene panel testing or larger testing? For example, covering germline predisposition to immunodeficiency and cytopenia. And I think this gets a little bit to another question that came up in my mind, which is, you had mentioned, Dr. DiNardo, that at your center, at least, you provide genetic testing for almost everyone. And I was curious about who are the people you don't provide genetic testing to, and then maybe we could build on what that panel, I think you said it was a fairly large panel, but I'll stop there.
So not everyone is referred for genetic testing, but certainly, the genetic counselor, Kevi Gerstein, who works with me and myself, we kind of review all the new patients who are referred to our department, and see would they, potentially benefit from a referral. So I'm looking at, patients who are younger, patients who have a family history, or patients who have kind of mutations on our panel at a near heterozygous frequency of, any of those potentially inherited genes. And so those are the kind of things that kind of get a patient flagged to come see us for a genetic counseling referral. And then, what type of panel are we doing depends a lot on, the specifics of the patient. So if the patient is coming to me because they have 2 DDX41 mutations identified on their panel, I'm going to be doing a single gene, germline confirmation of that DDX41. If a patient is coming because they have, a history of a personal and family history of autoimmune diseases and lymphomas, that's a very big, almost can of worms, in my opinion, where there's like so many different immunodeficiency genes. And it's really hard to say like, okay, I'm just going to do like a 10 gene panel for that patient with the primarily myeloid, disorders that we have identified. So a patient like that, we do kind of the full immunodeficiency panel. But we don't get too many insurance denials of genetic testing, but the ones that we get are almost always because we're doing large panels. And that flags, some people's insurance and says, like we are not paying for more than, sometimes it's 50, sometimes it's 100 different genes. So you have to be a little bit careful. And that's where the genetic counselors are super helpful, because they can do kind of the pre-authorization of investigation. So before you send off a skin punch, you just, heavy calls and make sure we know what we can get approved for that particular patient based on their insurance.
Great. Dr. Helena, do you want to speak on what you do at your center?
Sure. So maybe I can chime in, right? As a researcher, we always want to have everything, right? So ideally you would have whole genome. We can easily get whole exome targeted panels. But then of course the interpretation is very, very difficult. And we can more easily interpret genes where we know the mutations, where we know what they do. And so if you end up getting a large panel where you have a whole exome or so, then what do you do with that data, right? So do you go back every time a new gene is discovered? So that has to be organized. You also don't want people to, give them false security. So yeah, we sequenced your whole exome and now we know everything or so, because I think future discoveries may change that knowledge. So, I think it's just important. And then, healthcare cost, you have to be responsible. So I think if you can get away with a targeted panel, I think that's very good. But if you don't know, and then need to go on to, if you don't find easy answers, then you may have to keep digging. You need a good team.
Yeah, I'll add, it is always the patients where we're not sure exactly what we're looking for, that we do the very large panels that, the more genes you interrogate, the more variants you're going to find. And so you'll end up with somewhere between, 2 and 5 variants of uncertain significance. And sometimes in genes like I've never even heard of, despite the fact that they're on these panels. I'm like, I don't know what to do with this information. So sometimes it's, you think it's going to be helpful, and sometimes it is, but sometimes it just adds confusion.
Yeah.
Yeah, I agree.
Okay, good.
That's kind of what we've tried to do too. Like if there's a specific like DDX41 kind of confirmatory test, we're just doing very targeted analyses. And then where, I think we've had a hard time getting insurance approvals here. And I think that really depends on kind of state to state and where you're practicing as well. It's been interestingly challenging here. I think the patient population is also different. So I think I think at least in my practice here, we've been not sort of fishing a lot and getting large panels, just, for the sake of simplicity. But I think as kind of Stephanie mentioned earlier, I think the more information, the better from a research perspective, but being able to go back and, re-annotate those, unknowns, the VUSs is a hard task to do. And then reporting those back to patients, and it comes in a HIPAA and a lot of mess that we create.
Yeah, I think that's a really important topic that I don't want to lose sight of, which is the VUS topic. And maybe I'll provide an example case. So, let's say you have a patient where they have a clear family history of, heme malignancy, and you do a large enough panel of hereditary heme malignancy genes, and RUNX1 comes up, but it's a VUS, and they're sitting in your office and they have MDS or AML. What do you do?
Well, you gave me a nice patient case, because RUNX1, you can usually see it phenotypically, right? A patient with a germline RUNX1 really should have some sort of at least mild thrombocytopenia or like bleeding tendency. And if you can identify family members who also have that same phenotype, you can test them potentially and identify that RUNX1 VUS. And then you can actually submit that patient and their family and get that VUS defined as a likely pathogenic variant if you have kind of the phenotype to go with it. So it's
if you have the phenotype, the phenotype, you would
Yeah.
proceed as though it's pathogenic. You would say, okay, I'm going to treat you and manage you, and I'm now going to offer regular monitoring to your family, because to me, this is like crystal clear. This is definitely behaving like a pathogenic variant.
I have a patient just like this, and I see him, and in my mind, he has a pathogenic RUNX1 mutation, but I'm very clear kind of in my discussion to him and in my notes that we haven't truly proven this yet. And there's a chance that it's a red herring and there's something else that is causing this. But it depends on the sophistication of the patient, how well they actually understand VUSs. A lot of people don't understand it. But I'm kind of hesitant to kind of say out loud to hundreds of people that I treat VUSs as pathogenic, because you just have to be so careful. Most of the time, in the world of cancer genetics, VUSs get interrogated and identified ultimately to be benign. So you have to be really careful with attributing, disease to a VUS.
Well, and I think to the point you made earlier during your presentation is that this is a new field, right? Yeah. And we're still learning. And so maybe I'll just put a plug that if any of you on the call do identify VUS and you see clear phenotypes, please do submit so that we can advance knowledge of these diseases. But Dr. Rangaraju or Dr. Helena, do you have anything else that you'd like to add, or how would you manage a patient like that?
Yeah, I mean, I think it's kind of exactly like how Courtney said. You're looking at the phenotype, you're looking at the family history, you're looking at the patient in front of you, and then putting that together. I think I would probably do the same thing where if I have a VUS, be it RUNX1 or any other kind of gene that has a very clear family history or a very obvious sort of phenotype, I would treat it in my mind as being pathogenic, but with a clear kind of saying that this is not a known pathogenic kind of variant, but your family seems to be behaving like that.
Yeah, I would, I think, also like to point out that it's a highly collaborative field across the US, and really across the world. And I think if we don't know, we reach out to the experts, right? The ultimate goal is it's always about the patient. It's always about doing the best. And so we don't know, we refer patients to, Lucy Godley, to Courtney, it doesn't matter. And, and in the time of telemedicine, email, phone call, Zoom, it is actually so much easier to pull in the experts. And so we never hesitate to ask each other.
Well, that's a great point. Thank you for mentioning that too. And part of this type of webinar is to highlight that you all are here and ready to help others who are sort of managing these kinds of cases and wondering what to do. So thank you for that comment. I'm going to read off the next question. And I know that Dr. DiNardo offered to stay a little bit later. Dr. Helena or Dr. Rangaraju, if you are willing to stay a little bit longer, really appreciate it, but also understand if you have to jump off, because there are still some more questions and we'd like to try to address them as much as possible. So the next question is about, can you provide any insight on the significance of a somatic mutation, for example, a JAK2 V617F mutation, identified in an asymptomatic patient without a known hereditary heme malignancy predisposition? Is there any way to predict whether the somatic mutation will drive a malignancy? So a bit different kind of question, but
yeah. So I mean, this almost certainly is clonal hematopoiesis, right? So CHIP is the term, the phrase we give for kind of somatic mutations, which evolve over time and ultimately do have an increased lifetime risk of developing a myeloid or any sort of hematologic malignancy. Actually, it's similar in idea to MGUS, so like a monoclonal gammopathy, which ultimately can lead to multiple myeloma. And so we do, academic centers around the country are setting up CHIP clinics where they are seeing patients who have these different different myeloid mutations without an actual myeloid malignancy. And JAK2 is one of the ones that's a little bit more kind of penetrant in the sense of, turning into an ultimate, myeloid proliferative neoplasm in this case. So it is something that I would think about referral to a CHIP center.
Yeah, and then maybe for the JAK2, the important thing also is that there is a propensity to thrombosis. So it may not be so much about the actual malignancy in this case, but thinking about, okay, is there a risk for thrombosis? Would you have to prevent, right? Once there's thrombosis, you treat, but would you actually think about preventing? And the variant allele frequency, and CHIP can be very small, 2%, 5%, 20 or larger. And that makes it very distinct from germline, where it's really 50% or more, and it's every cell in the body. So this is specifically just in the blood.
Perfect. I have a lymphoma question. I don't know if any of you are prepared to speak on a lymphoma question. We have our myeloid malignancy experts here, but I will throw it out and maybe tell me. So it seems like our knowledge of germline mutations for lymphomas is not that advanced as myeloid malignancies. I have a 38-year-old woman with DLBCL, and her son has a Bruton's I don't think I can. I think it's A-gamma globulinemia, and it is the patient. Is this patient appropriate for referral for germline testing? So in other words, does that suggest that maybe something's underlying?
I would say yes, the patient is appropriate for genetic testing, and that is a patient where I would be thinking about one of those larger immunodeficiency panels. Can I share a screen? I can for just a second.
I can, yeah.
Let me just show you, just as an example of how complicated it is. I have so many screens open. Where is it? Okay, here it is. So can you guys see this ridiculous nonsense? So we have this end lymphoma panel that we've been doing now for the past year and a half, and these are all the different circles of potentially inherited lymphoma genes. And many of them we just don't really know a lot about. So there's, it absolutely is an area where we need, more research and more kind of clinicians and research being done for the inherited lymphomas, because we just don't know as much, and there's clearly a lot there.
So I think that,
sorry, go ahead. No, I was just going to ask if, so the panel that you just showed, is this for the select patients that you're doing it on?
No, that's just our MD Anderson and lymphoma. So yeah, so that's, a presumed somatic panel, but we're finding all of these, polymorphisms and heterozygous variants that are probably germline, and do they mean anything? And it's really confusing.
Got it. Okay.
So I think that's probably in line with another question that came in around familial follicular lymphoma.
Yeah.
They have a family with 3 affected siblings and are just curious about next steps.
Yeah, I mean, certainly there's also a larger association with, occupational and exposures to lymphoid malignancies. And so, this patient may be from a family that, lived in a place or were farmers, or there's, it's not a single gene, it's a life exposure. But no, that was definitely a patient that I would think about referring somewhere where research testing can be done at least.
Great. Okay, well, I think we have just one final question, and that is, do we know why monosomy 7 is so common in germline GATA2? Do we understand the mechanism there? Any takers?
Either of you? Monosomy 7 is a common kind of secondary abnormality in MDS and AML, right? It's not just with GATA2, it's with SAMD9 and SAMD9L and, RUNX1 mutant patient. It is definitely important in promoting, malignancy, but exactly which genes and why, I don't know.
Yeah, I'm not sure either, but just in very oversimplified terms, I don't know if it's sort of like your first hit, second hit kind of phenomenon where you have a GATA2 mutation already that's germline, and then the monosomy 7 could be your second hit. But yeah, I'm not sure.
Yeah, I think
studies are on. yeah, studies are ongoing for that. A lot of people are trying to model these abnormalities in mice to understand.
Yeah, the sequence clearly matters, and we certainly see that in the research going on with RUNX1 FPD. Certain sequences can drive progression, and others appear not to do much at all. So I'm sure there's interactions that we'll learn about in the future. Well, with that, I think I can close this webinar. I want to again reiterate our appreciation for all three of you for being here and having this robust discussion. And I failed to mention that we also have the slides available, which Dr. DiNardo is willing to share. So thank you. And then also the recording. So we will send that out to all those who participated and all those who registered.